So, good evening. Can everyone hear me?
Yeah.
So my microphone doesn't work. We'll hope that yours does. Welcome to our February Great Presenters Program at the Wayland Library. Tonight, we're excited to have Wayland resident Dr. Alvaro Pascual Leone here to talk to us about brain health. Dr. Pascual Leone is a professor of neurology at Harvard Medical School, a senior scientist at the Hinda and Arthur Marcus Institute for Aging Research, a medical director of the Deanna and Cindy Woke Center for Memory Health at Hebrew Senior Life in Boston. He also serves as scientific director of the Barcelona Brain Health Initiative and is a co-founder of Linus Health and TI Solutions. I'll get some more chairs after I do my little intro. Dr. Pascual Leone is considered a world leader in non-invasive brain stimulation technologies. His research combines brain imaging and stimulation techniques to examine causal relations between brain activity, cognitive processes, and behavior in health and disease. A major current focus is to characterize and sustain brain health across the lifespan. He's a member of the Spanish Royal Academy and has been honored with many distinctions. He has published more than 850 scientific peer-reviewed papers, and his work is highly cited. He remains a practicing cognitive neurologist and dementia specialist today. Thank you so much to Dr. Pascual Leone for being here tonight. Just two housekeeping notes. First, we are recording this session for broadcast on Waycam, our local cable access station, and for the library's YouTube page, so you'll be able to rewatch and share. And second, Dr. Pascual Leone will speak for about 40 minutes, and he invites questions as they come up. So just raise your hand, but if you're on Zoom, feel free to put it in the chat and I will raise my hand for you. And now I will get out of the way, turn it over to Dr. Pascual Leone.
Thank you so much. Thank you all for coming, those who made it here. Thank you for those who are on Zoom, and thank you particularly to the Wayland Library, to Courtney and Steve for organizing everything. It's a pleasure to be here. So what I'm going to try to tell you about is a take-home message that while dementia, while the risk of losing one's own cognitive abilities as we age is an increasingly dangerous threat to human society, to put it in perspective up front, affecting 1 in 2 people after the age of 75, it is incredibly scary. Despite that enormous threat, I hope to convince you that there is much to hope, that there is something we all individually can do to minimize that risk, to have a healthy, fulfilling life, even if you develop an illness that can cause dementia. And finally, that if you do develop such an illness, by no means does it imply that obligatorily you're going to have the dementia. So I'll try to unpack all of that as we go along, but that's what I hope to share. Sure, how I'm supposed to move. Here we go. Before I get started, some disclosures. You've heard I'm the co-founder of a couple of companies. I'll mention one of them because it's relevant, but I'll promise not to try to sell you on how great it is. It is pretty great, but that's a different thing. But I'm also a member of the scientific advisory board for some companies making brain stimulation techniques, devices, and I'll share some of the potential that those approaches have. But the bulk of what I'll tell you about has absolutely nothing to do with any of these companies. Now, to put in perspective, brain diseases are the #1 cause of human disability today. They're a greater cause of disability than cancer and cardiovascular diseases combined together. It's largely a non-visible threat because the cost of taking care of people with cancer or cardiovascular diseases is largely a cost to the hospitals, to the healthcare systems. It's very visible. You go, you need chemotherapy, you need operations, you need radiation therapy, you need operating room costs and hospitalization. the cause of brain diseases, contrary to that, is largely something covered out of families' pockets. It implies taking care of loved ones, support, caregiving costs. But consider all of that, and brain-related disabilities today account for a cost of about 15% of the world's GDP. Again, to do a comparison, that is more than the cost of cancer, diabetes, and cardiopulmonary care together. It is the number one threat to the welfare of human society. It's not me saying it, it's the World Health Organization saying it. I know that it is popular these days to say how threatening the global warming is. I don't mean to minimize that, but if you have your brains capable of functioning, you at least can address or tackle that problem. The World Health Organization says brain-related disabilities not only are a cause of human suffering, they are the number one threat to human society. And that is happening at the same time as our life expectancy increases, which should be a cause for great excitement. We're living a lot longer than ever before. For the first time in history, there is more people 65 and older than children 5 and younger. It should be great for the value of wisdom in society. But aging is the number one risk for brain-related disabilities. I want to be very explicit. It's not the cause of them. It's the number one risk for them. It is not an obligatory consequence of aging to develop brain-related disability. But you need to do something, we all need to do something about it, or else we risk, as we get older, developing brain-related disabilities. So, contrary to what I was told, what I was taught in medical school, we've known for a long time that there are some people who seemingly magically age well until they are in very old age, and we call them brilliantly maintainers. Whereas those who do not, we call decliners. And we've known there are such groupings of people, and what I was told, what in medical school, what was a dogma, is that those who are maintainers are special, because those who decline are doing what you should expect should come with aging, losing capacities. We now know that is false. We now know that in fact pathology is what drives the decline of cognitive abilities. Let me be clear, that is not to say that as we get older there is no change in the things you can and cannot do. I used to be pretty good at using a tricycle and became unable to do so a long time ago. And it's related to aging, but it has nothing to do with my overall health ability. It just has to do with my joints being too clunky or whatever. So in brain function terms, our brains change as we get older, as we live, and with that, our cognitive style is modified, and therefore there are things we used to be able to do that we can no longer do, but there's also things we couldn't do that we can do later on in life. Arguably, that is the foundation of wisdom. We know that the connections between brain areas enable children to very quickly learn what cognitive neurologists would call arbitrary mappings. There is absolutely no reason why this should be called a glass. It's just somebody decided that makes sort of sense. And that children are incredibly good at that kind of association, except as we get older, we become really good at thinking, this thing that I may not even remember what it was called. I used to know, but I can't come up with it. But the transparency of it, isn't it cool? It reminds me of the shining that was there in my grandmother's house that lit a staircase and allowed me to go up that stairs. But by the way, that staircase, that was copied to some, you get the idea. We can connect different disparate things, and with that create the fabric of culture. And that is the opportunity afforded by older brains because of the way that connections are. That is the risk, if we don't maintain healthy brains as we get older, that society doesn't benefit from it. So, decliners are ultimately manifesting pathology. Fortunately, our brains have something that we call reserve that allows, in the face of pathology, to still function. And I'll tell you more about that. It's an exciting thing, but it gives two targets to unpack. One is what can each one of us do to maximize the reserve? And what can each of us do to minimize the risk of pathology? So that's what I'm going to try to tell you about. To start with, it's worth thinking about what defines brain health. Since the Romans, we have come to believe that in order to have a healthy brain, you need a healthy body. You all have heard Juvenal's sort of dogma. But we now know that it also is true the other way around. You cannot have overall health without a healthy brain. In fact, the number one target for health, overall health, is a healthy brain. People with an unhealthy brain, if they have diabetes, have worse control of the diabetes. If they have cancer, have worse spreading of the cancer. If they have cardiovascular disease, have worse cardiovascular disease, and a long list of other things. And the reason why is because the brain exerts a monitoring of the body and exerts healing powers, literally, we call them salutogenic mechanisms, to influence your overall healing. That is so powerful that nature has come up with, frankly, horrible solutions to try to bypass that. One of the reasons why pancreatic cancer is particularly deadly is because pancreas cancer cells make a substance, sort of like a morphine, an opioid, that shuts down the salutogenic mechanisms of the brain, so that it impairs our own brain's capacity to detect an abnormal growth in the pancreas until it is frankly too late. So we need a healthy brain to have a healthy body, but what can we do to have a healthy brain? As part of this Barcelona Brain Health Initiative, following 7,000 people over the past 6 years, we've asked the question, what things that each one of us could potentially change, how much we eat, how much we sleep, what kind of cognitive challenges we pose ourselves, what social relationships do we have, how much do we exercise, this kind of modifiable lifestyles. We've tried to ask, what is it that makes it possible for some people to maintain brain health? What are their characteristics? What we've come to learn is that about 60% of overall health is determined by brain health. So if you maintain a healthy brain, put it differently, you're 60% more likely to stay healthy. The second thing we've come to learn is that more than 60% of the variance of brain health is determined by 6 pillars. Purpose in life, in purple, I'll talk more about that in a second. Sleep, social relations, physical exercise, cognitive exercise challenges, and nutrition. But perhaps the most interesting finding, at least to me, is that what we've come to learn is that the weight of these different factors is not the same. In fact, purpose in life, together with social relations, have the strongest impact and mediate the effect of the others. To put it provocatively, if you have a feeling that you're properly supportive, if you don't feel lonely, not alone, but lonely, and if you have a sense of the reason for you to be alive, a sense of purpose, a commitment to something, if you have those two things, you can allow yourself, I'm not recommending it, but you could allow yourself to not exercise, to eat too much, and to not sleep. So it's important to address all of them it's particularly important to remember that you need the social connection and that we all need a purpose in life. And that purpose in life needs to be something that transcends us. It's not about making money. It's about changing the life of those who cannot shelter themselves in the winter. In order to do that, I need to make money. That's okay. But it cannot be about you. It has to be transcending of us individually. It could be religious, or it could be your grandchildren, or it could be both. It can be little and it can be small. It can be changing, but it has to be clear in each one of our minds. Because the importance of that opportunity is so big, if we were to be able to do these things, we would promote brain health. And because that is so critical for human society, given the risk of brain-related disabilities, the United Nations has declared the current decade the decade of healthy aging. And their motto I like, because their point is, it's not about adding more years to life, it's about adding life to the years. Whatever years you may have, let's fill them with life. So I want to unpack that a little bit more, get a little deeper, and focus it more about dementia. Because if we ask, has been done in the United States and in Europe, if you ask people, what is the number one condition, health condition that you fear the most, 98% will say dementia. I don't know what you would say. I would say dementia for sure. I remember my mother, who sadly passed away of a very aggressive form of cancer, saying, "We are so lucky." I thought, you're dependent on morphine, hardly able to sleep. We were sitting in the kitchen in the middle of the night. I couldn't quite see her point, and she explained, "I'm in pain, I get medication, it's hard to get out. But when I'm here, it's me here." It's that risk of losing the essence of who we are that we fear would come with dementia. And in fact, because of that, perhaps, if you ask people whether they would take a test to find out if they are at risk of having dementia, or if they have an illness that would cause dementia, in the United States and in the UK, in studies of over 15,000 people, 98% say yes, they would, even if there was no treatment for dementia. And the rationale people give is, that way I would be able to prepare myself, I would be able to prepare my loved ones, I would be able to choose what I want to do with my life while I have control of my life. And if in the process you can find out a treatment, I'll appreciate it. But I think it's very important, and yet in healthcare we haven't quite come to terms with that. Right now, dementia affects an enormous number of people. It plays out in different time courses. Oftentimes people think dementia is the same as Alzheimer's, and we fail to realize that Alzheimer's is just one illness that can cause dementia, is the most common cause of dementia, but doesn't have to. 1 in 4 to 1 in 5 people who have Alzheimer's disease never develop cognitive problems. We know that since the religious order study in Minnesota that showed that 1 in 5 nuns who passed away and was found to have Alzheimer's disease in their brains, in the pathology, in the autopsy, had never had any problems, had never had any cognitive problems. Those were particularly the nuns that devoted themselves a lot to others. And it's part of the foundation of what has come to be conceptualized as reserve that I mentioned before. Those who do things that promote your brain capacity to cope with pathology, even if they develop Alzheimer's, are less likely to be disabled by it. So, it's the number one cause, it's the most common cause, but it's not an obligatory cause of dementia. And it's not because the person matters. It's not just the disease. It's about who is the individual who has the disease. The same way that matters the caregiver. If I want to take care of somebody with dementia, I need to make sure that their primary caregiver doesn't become distressed, doesn't become depressed. Because if I don't attend to their caregiver, the risk of my patient of developing disability increases by tenfold. So it's about taking care of the patient at the end of the day, not about taking care of the disease. And it's a growing problem because as population grows, the risk of these diseases increases. But the most important take-home message, from my perspective, about all of this is that 80% of cognitive disability, brain-related disability due to dementia, is in fact either due to undiagnosed diseases. People are told, you have dementia, but there is no diagnosis behind it. It's like saying, you have fever. Well, what is causing the fever? Well, it's really bad. Something is causing it. Well, that doesn't help me treat it. So it's either undiagnosed, or it's due to modifiable risk factors, and you could be doing something about them. In other words, it's preventable. So why are we not preventing it? Why are we suffering a growing number? Well, the reason why we're suffering a growing number is because contrary to what happens with much of medicine, even though brain, I'm telling you, should be the number one target of brain health, by a raise of hands, tell me how many of you have gone to your PCP over the years and your primary care physician has said, okay, it's time for your brain check. We're going to do your brain check now and see whether we need to do something about it. They've done EKGs, they've done blood tests to see if you have diabetes, but we don't do brain checks, even though, by the way, it's covered by Medicare. But it's one of the approved benefits that we all have in Medicare, but the system is not ready for it. And so we live without brain checks. The system, as it turns out, is sort of like this. The person in the middle of the system is me, is the super expert in dementia. I'm going to make an argument that that is completely wrong, so allow me to put myself in the middle to start with. But the expert is the specialist is in the center because the system is completely reactive. We wait for somebody to complain. Because of the nature of the disease, it's generally not the patient, it's generally the family. Mom, dad is more forgetful. And at the beginning, we're not really sure. Is she really more forgetful? Mom has always been a little forgetful. And she just doesn't care. She's just getting old. So we wait, we doubt, we hesitate, the symptoms start showing up, eventually a complaint comes about, eventually we check with the primary care physician. The primary care physician, for the most part, doesn't know exactly what to do about it, doesn't have the tools to do the appropriate thing, and so eventually refers to a specialist. The specialist starts doing testing, diagnosis, treatment, and eventually starts to see an impact, and what that impact does today is promote brain-related disability, not benefit anything, ensure that we're disabled. Why am I saying that? Because what has happened is that since the illness started, at least 10 years have gone by until symptoms and complaint happen. In the case of Alzheimer's disease, on average 15 years. So you've wasted, in quotes, 15 years that you could have done something about it. We could have done something about it if we had known. From the complaint to actually seeing a primary care physician for purpose appointment. In Boston right now, the delay is about 3 to 6 months to get to see your PCP for a lengthy assessment. The average time to see a neurologist in Boston referred to the PCP is 9 months. Now, put in perspective, Boston has more neurologists than the entire United Kingdom, and the United Kingdom has more neurologists than all of Africa. So if you think that's bad, imagine vulnerable populations. They're going to be affected disproportionately with this. And then there is a few months to a year until treatment starts. By the time treatment starts, it's no surprise it doesn't work. It's way too late. The brain has changed to adapt to that damage, and what you're really dealing with is a downstream cascade of whatever the pathology was. But because in medicine we keep trying, no matter what we're really doing right now is with every dollar we invest, the more money we invest in this, the more disability we promote. Of every 12 months of extended lifespan with the dementia that we gain, 9 of the 12 months are disability. Those are not the years any one of us wants to live. That is not adding life to the years, that is perpetuating life despite disability. So what needs to change to be able to modify this? We need to transform the approach. The approach right now is we wait until symptoms and complain to start doing something about it. But we forget that before the symptoms develop, for a decade or more, there is an illness. And before that, there is health. And the reason why the illness hangs along for so long until symptoms develop is because the brain has capacities that we call resilience and reserve to cope with pathology and avoid it manifesting, to keep going, to put in another gear. It's a double-edged sword, because if the brain is coping with pathology, pathology keeps increasing. If you do nothing about it, at some point there is so much pathology that the brain cannot do anything anymore, and then it manifests very fast. But it gives a window of opportunity to promote that resilience, to promote the brain health, and to reduce the risk of dementia. That's the approach we're trying to take at the Walk Center. One of the challenges in the dementia care layout that I've made is that this is not a kind of illness that it's a one-stop shopping. You come to see the neurologist and they make a diagnosis, and now what? It's the rest of your life living with that. But you're going to see me again in 6 or 9 months. What do you do during that year? You need a kind of support and care and coaching and guidance that acute care hospitals generally don't give. So that's what we try to develop at the Walk Center at Hebrew Senior Life is first enable brain checkups to ensure early diagnosis, leading to early intervention, make those interventions very personalized, not about treating the disease, but about treating the individual who has the disease, couple it with lifestyle coaching and support, because addressing all the things that are involved is cumbersome, is difficult for all of us, and link it to family and caregiver support. I want to unpack that a little bit and give you some examples. So it's not sufficient, as I was saying, to say you have dementia. For a neurologist, dementia means that you have difficulties in more than one domain of cognition. Memory is one, attention is one, language is one, finding your way around, making decisions. These are all domains of cognition. To have a dementia, you have to have problems in more than one. Those problems have to be getting worse, so they need to be progressive. And finally, they need to impact your day-to-day life. Only if you have those 3 criteria, you have dementia. But to put it in perspective, that happens if you're very stressed, not sleeping well, drinking too much. And it's very treatable, it's very curable. It's not Alzheimer's disease, but it will manifest as dementia. It happens if you have depression, very treatable if diagnosed appropriately in most people, treatable. But it requires diagnosis. So it's a label of a symptom complex, really, is the point I'm trying to make. And we need to get to the causal diagnosis. Is this dementia because of Alzheimer's, because of diffuse Lewy body disease, because of multiple strokes? What is the cause for that clinical manifestation of dementia? In order to do that, one needs diagnostic tests. One also needs to then think about who is the person who has the disease, because depending on that person, the manifestations may be different, the risk of progression may be very different. I'll show you data to this in a second. And in order to do that best, we cannot wait until people complain. we need to do the same thing that we do for cancer or for cardiovascular disease. We need to embrace preventative measures and do assessments to empower each other to follow up and do the right thing. So let me give you some data to illustrate this. I'll walk you through this graph. It's a little complicated. So before dementia happens, there is something called mild cognitive impairment. I told you dementia has 3 criteria: multiple domains, progressive, impacting your day-to-day life. If it doesn't impact your day-to-day life, you may have cognitive problems that are getting worse, but we call that mild cognitive impairment. And we know that depending on the kind of domains that are affected, we can subclassify the mild cognitive impairment. We can say it's mild cognitive impairment with a lot of memory problems. We call that amnestic mild cognitive impairment. Or we can say it's a mild cognitive decline without memory problems. It's visuospatial difficulties, it's decision-making problems, it's attention. We call that non-amnestic MCI. It turns out that if you have amnestic MCI, over the next 12 years, 80% of people will develop dementia that becomes disabling. But if you have non-amnestic MCI, only 40% will develop it. The reason for it is because the causes for one and the other are very different. Amnestic MCI is mostly Alzheimer's disease. Non-amnestic MCI is things like depression and lack of vitamin B12 and other things like that I mentioned earlier. However, if you take people with non-amnestic MCI who are frail, they don't exercise regularly, they walk slower, they're losing grip strength, they don't exercise. That's the dashed line in blue. You might as well have Alzheimer's disease. The risk of progression to dementia of non-amnestic MCI in frail individuals is as high as the risk of progression in people who have amnestic MCI. And those who have amnestic MCI, if they are frail, progress a lot faster. So it matters who has the disease. It matters what the disease is, but it matters who has the disease. And it matters not only to understand the issues, but to also have targets of intervention. If you want to prevent dementia, you should make sure that your hearing is as good as it can be. If you're losing hearing, get hearing aids, because that accounts for a 10% risk of disability. If you have cataracts, you should have surgery. Why? Because your loss of vision will increase your risk by 10%. And the risk of cataract surgery in healthy older adults is the same, as low as it is in younger individuals. If you are overweight, you should lose weight. And I know these things are easy to rattle down and very hard to do, all of them. This is not trivial. This is an effort. But it makes a difference in terms of the risk of progression, even if you have an illness. Now, you could say, well, maybe this is something you learn from following people, but what if you do an experimental study? What if you take people and actually have them do these things and see what happens down the road? Well, it has been done. It's called the FINGER study. It's now a worldwide study. It's an acronym for Finnish, Initiated, and so on. Finland launched the study, and we know that these things work. It reduces the risk by 40 to 80%. But it's a lot of things to attend to, and it needs to start early, ideally lifelong. So, there are maintainers. That's what should happen if we had the right lifestyles, habits, environmental circumstances. Some things we can control, many things we can't. If I'm born to a low socioeconomic status, I can't control that, and yet it's a huge risk factor. If I grow up in an area with a lot of contamination, I can't change that initially, and yet it's a big risk factor. There are aspects that are public health issues that we need to address, but there are aspects that we individually can control, even if we develop the pathology. And then we have this thing called reserve. this ability in the face of pathology building to maintain function. And it turns out we can measure it, which is a good start, because otherwise, what does it really mean to have reserve? How much of your reserve are you using? So let me give you an example of how we can measure it. You can have somebody, before I give you the example, let me give you an anecdote that illustrates that probably most of you have experienced. When I'm driving down a street and it's rainy and it's dark and I'm enjoying the drive and I'm listening to music and it's great and it's blasting out of my music stereo, but I'm coming close to the house of this fellow I want to go visit. I don't know exactly the house, I've never been there, but I know I'm on the street because I saw the street name. And now that I'm getting close to the house and I need to read the number on the street sign, what do? I turn on the music. Why the heck do we turn on the music? Why is hearing relevant for my ability to see the number? It's relevant because both of those things require my brain, and my brain can only do one thing at a time. And in order to do the one thing it can do, it's shifting resources to do it. And the ability of the brain to allocate resources is a metric of reserve. So we can turn that into a very quantitative experiment. We can ask people, I want you to stand still. I want you to stand there still, not move. And we can measure it. By the way, so can this. I'll come back to that. This knows exactly how much I'm swaying right now. But we can measure it with a force plate. And then we can tell the person, now I want you to keep standing, but also count backwards from 100 in sevens. So you stand there and you go 100, 93, 86, 79, 72, 65, and lo and behold, without you wanting to, you move a little bit more. And how much more you move, the cost of the dual task, the cost of a challenge of doing two things at once for your brain, is an inverse measure of your reserve. The more cost, the less reserve. Is that a fixed thing? Turns out it's not. You can do something about it. This is the same person. This is the same person 6 weeks later. So what has happened? What did we have that person do? We taught that person to meditate. It turns out a number of things, meditation, yoga, tai chi, change specific brain networks and enable us to restore our reserve. But if we don't pay attention to it, then we are draining our reserve, and when our brain needs it, we might find out that we don't have it. So I was saying, this knows it. So as I'm walking and talking on the phone, my phone knows how much I'm moving. I don't. I don't want the government to know. But I'll be okay if my physician knew, because that might be a way in real life to actually capture reserve. And you've experienced it, I'm sure. You're walking along, you're having this really deep conversation with somebody, and it gets really complicated, and you need to calculate, and what you do is you stop. The person goes, hey, what happened? No, it was really complicated to think about this. But we were walking, for God's sake. Why can't you keep walking? Because reserve is exhausted in my brain. So if we have a way to do this as a passive application, as an algorithm, we would have a way to empower each one of us to know how bad are you tanking in terms of reserve. What can you do to increase it? That's the idea. This is my mention of Linus Health that I said at the beginning. This is the idea behind this company, Linus Health, is can we have practical solutions to empower individuals to have metrics of their brain health so that they can make the choices, the decisions that they want to do. The talking and walking is one such example. At the end of the day, it's about digitizing, capturing the process by which you do whatever you do, but importantly, turn it into actionable insights. So not the score on your testing is X, but given these scores, these are the things you should do to improve your function. That sort of idea. Now, I want to get a little deeper into brain neurophysiology, if you allow me. So what we're talking about at the end of the day are behaviors, cognition, relation with others, and so forth, are manifestations of the functioning of our brain. And in the setting of health, our brain has a certain structure giving rise to a certain pattern of function. Each thing we do, listening to this talk, giving this talk, preparing for it, enjoying it or not, thinking this is really boring, whatever it is, has a specific signature in your brain, a signature of a pattern of activity in specific spots at a given rhythm. We call it a spatiotemporal signature. And so the spatiotemporal signatures are the hallmark of each thing we do, each emotion, each thought, each behavior. In the setting of illness, any illness of the brain, there is a damage to the brain, alteration of the structure, and with that, a change in the function of the brain, an alteration of that spatiotemporal signature, giving rise to the symptoms. So if my memory is worse, it's because my spatiotemporal signature of memory has been altered. If I can measure it, and we have the tools to measure it in humans, maybe I can modify it. I can do an intervention that selectively in me takes that altered spatiotemporal signature and forces my brain to function normally. And if you do that, you would expect the symptoms to get better. I'll show you that that's what happens. But in addition to that, it turns out by forcing the brain to function better, it restores some of its structure. Our brain is plastic, is modeled, is modified by what we do, and if we force it to function a certain way, it's modified to function, quote, better, and with that restore some of the structure. So what does that look like? So we need to capture all your brain activity. We can do that with high-density electroencephalography, for example, linked to a brain MRI. It's rather involved technologically, but we can characterize specifically where and how is your brain not functioning properly to account for this dysfunction that you have. In this case, a memory dysfunction. Because these people I'm going to show you results of have Alzheimer's disease and their memory is poor. We can then define the target for each one of them individually and equip them with the system they take home so that they make their brain for 30 minutes a day function, force the brain to function normally. It's like a swimming cap that injects a very small amount of current to the right areas of the brain at the right function. They can be doing whatever they want to do during that time, or they can be engaged in some tasks to maximize the effect. These are the results. What you see in the first graph is the pattern of activity in a memory task in somebody who is old but cognitively intact. Next to it, you see these participants in the study with Alzheimer's disease and memory problems, and it doesn't take a lot of looking to see that there is a lot of change in the signature of the activity. And we can localize where is that alteration in the brain, and we can make the brain function normally. And what you see here is the results of that making the brain function normally. This is somebody who, over the course of 2.5 years, has progressively lost memory capacity from a normal level of 15 out of 15 on this scale to 0 out of 15. Functionally, what that means is he went to play golf but doesn't remember going, doesn't remember with whom, doesn't remember really what golf is to be able to explain it to you. After 14 weeks of intervention, remembers to have gone to play golf, with whom, what they had for lunch, and what the score was. The big challenge is, what can we do to maintain that way of functioning? We can make it function normally. We can derive a benefit acutely. How can we make that sustained? That's where we are. But at the very least, we know we can induce the normalization. It's not a foregone conclusion that you lose the ability. That can be coupled, has to be coupled, with lifestyle modifications, because as I was mentioning, any number of things we know will account for about 40% of the disability. And therefore, it's not sufficient to diagnose. It's necessary, but not sufficient. It's not sufficient to identify the dysfunction and intervene with medications or with these kind of interventions. It's also critical to address these risk factors, to control your diabetes, your blood pressure, your body mass index, hearing loss, and so on. If we do both of those things together, the impact is thought to be about 60%, 40 to 80%, depending on the studies, in terms of reducing the risk of disability, even if you have disease. It won't take it away, but it will lengthen the normal functioning for a significant amount of time. And a key component is the caregiver support, because we're not isolated. As humans, we are social beings, and the well-being of our loved ones impacts us. The risk, as I was saying, of dementia getting worse is hugely increased if the caregiver develops depression. And the risk of depression in caregivers is about twice the rate of the general population. It's challenging to be a caregiver. So I want to finish with one visual. And I was trying to explain to my son, sorry about that. I was trying to explain to my youngest son what we were trying to do with this transformation of healthcare for dementia. And he said, well, basically what you're talking about is doing a pit stop model. And I know nothing about car racing, but he does. And so I asked him to explain. And so it turns out for many, many years of car racing, cars would go on the track and keep going until they broke down. And if they broke down, a group of mechanics would run out, try to retrieve it, try to fix it. A lot of time would go by. By that time, it was too late. You would basically lose the race. Until one day, Juan Manuel Fangio, who was a superstar at the time, but very late in his career, did something that had never been done before. He started the race very fast, got some lead from the others, and radioed his team, said, I'm coming in so that you can change my tires. And the team said, what's wrong with your tires? He said, nothing. Why are you coming in? So that nothing happens to them. And they said, but we don't do that. They said, no, but we're going to do that now, because I won't be able to sustain driving as my tires get old, because I'm old. And so because I'm old, I'm coming in so you give me fresh tires so I can keep pushing. And they'll keep coming closer and closer, but I'm going to hold them off. Because he was Fangio, the team said, okay, come on in. And so they did that, and he won the 57 Nürburgring, last big win of his career. There was a little team watching this whole thing happen called the Woods brothers, the team. Glenn Wood was the owner. And Glenn Wood said, maybe it wasn't just Fangio, maybe it was that stop that the guy did. And so he risked it, and for the Daytona 500 a number of years later, with a very unknown driver against the all-powerful Ford team, came up with a strategy up front of scheduled pit stops. After these many turns, you're going to come in for a checkup. We're going to change your oil. You're going to come in afterwards. We're going to change your tires. And they did that, planned pit stops. And they not only won the Daytona 500, but changed racing forever. They were acquired by the Ford team, by the way, because it was easier to acquire them than to just keep going. What I'm arguing is that we need to learn from car racing to win the race for brain health. We need each one of us to be cognizant that there are things we can and should be doing. Maintaining a purpose in life, having good relations, investing in them, exercising, maintaining cognitive challenges, sleeping enough, not eating too much. All those things are important. But we also need pit stops. We need a primary care team to periodically have a stop and do population screening for early detection and early intervention, brain checks. We need to be empowered when we can make decisions to make the right decisions for ourselves, which requires significant education. But they're going to be different for each one of us and each family. And then we need technology to allow us to monitor longitudinally so that we can tweak what we're doing and keep adjusting it for our own well-being. I think if we do that, we can then, for the likes of me, choose to see them if and when we need them. The vast majority of us won't need the specialist because we will be maintaining brain health even in the face of illness, which would be a significant gift to our society and to each and all of us. Thank you so much.
There's many questions online.
Awesome.
So one person asks, should I be going for a brain scan as a regular part of my physical checkup, even with no symptoms? Is that something I should be asking for?
That's a good question. So not a brain scan. Most people think of brain scan as a brain MRI or a brain CT scan. At best, for the most part, that gives you the brain structure. It's like taking a picture from up high from Boston and saying, the traffic looks great. You're not seeing the traffic in Boston, you're seeing the roads if you're lucky. But what you want is to know the traffic. And so for that, you need a functional assessment. You need to evaluate the function. If you evaluate the function and if there are abnormalities, two ifs, then maybe a scan is appropriate and necessary. So I would say don't routinely do a brain MRI. I know there are companies that offer that as a solution. That doesn't work. It's the wrong thing to do. What you need is an assessment that screens how you're doing cognitively, and if there are deficits, if there are abnormalities, then you may need additional tests.
So is that what you would ask your primary for, a cognitive assessment?
Yeah, but if any one of us goes to a primary and asks them for a cognitive assessment, the challenge is that they're very busy, they have a very tight workload, it's a difficult thing to do, and the tools that are available right now for primary care physicians to use, even if they want to use them, they're not the most sensitive ones. Many people have heard, because it was in the news, because of President Trump saying that he had scored perfect on a given test called the MOCA test. And that's one of those screening tests. And it's great that some primary care physicians, including his, did the MOCA test. But it's not a very sensitive test. And so a score of 30 out of 30 or a score of 26 out of 30 on that kind of a test is normal. But if I had a score of 26 out of 30, I would have a lot of difficulties and a lot of problems. That the reason why you lose specific points matters and matters a lot. And so it's more complicated than just those screening tests. So we need better tools, in other words, to be able to do it. So if we go to a primary care physician now, we need to almost tell him or her ahead of time, we're going to want to have this. Is it possible to do? Can we plan for it? And not go with what most of them would do, which is refer to somebody, because that opens up a whole other kind of worms, including the delay I was mentioning. Does
dementia reduce the aspect of memory in people? Now, I notice myself, I'm 88, and my memory is excellent. Remember things that happened years and years and years ago. But does that diminish in younger people if they don't train themselves accordingly, or?
Well, there's lots of good things in your question, so let me unpack a few of them. So if we don't train memory, the memory capacity, just like a muscle, becomes less. So we know, in fact, there's studies showing that the memory capacity of current generations is significantly less than it was before. Why? Because even I remember quite clearly that we needed to learn by memory long poems that I can still tell you. And that is like anathema these days. I mean, you cannot ask that in school because that's bad education. We want creative minds. And that's okay, except it means your memory capacity becomes somewhat less and somewhat impaired. So there is some of that, of practicing having a value. But what we really want to maintain is not the raw capacity of remembering the things we're learning, but rather the capacity of remembering things that happen in life. And so having the machinery to make new memories and to retrieve them, which is again a little bit different. And with age, that capacity goes down, but should be maintained overall. So in the case of dementias, any type of dementia, in almost all of them, memory is one of the early signs. It's certainly the case in Alzheimer's disease. It's not the case in some of them, but in most of them it is the case. And just like you said, is the recent stuff, is making new memories, is retrieving recent memories. Whereas retrieving old things that happened a long time ago tends to be sustained. And retrieving memories that we call procedural, doing the things that you've learned to do by doing them, riding a bicycle is a typical example, that's totally preserved. That's not a problem.
Do we erase the negative factors?
Fortunately, most of us do, but it's a great point too that the capacity of the brain to forget is actually a very important component of ultimately a healthy life, as we've learned from the Harvard study. Yeah.
You mentioned the nun who was diagnosed with Alzheimer's but was asymptomatic. Was this picked up on radiologic exams or on postmortem?
In that study was postmortem. But the point is very well taken that today we have tools to pick it up in life. So a spinal tap, and I think in a few years, a plasma test, a blood test, would allow us to tell whether somebody has Alzheimer's disease or not. It will not resolve the question whether somebody has dementia due to their Alzheimer's disease, but it will allow us to say whether somebody has Alzheimer's. Yeah.
I'm wondering in this balance that you have between sort of somebody getting sick and sort of lifestyle issues that can mitigate against the illness. My picture is people get sick, and there's some degree of randomness in that, and then it creates pathology. And certainly lifestyle can be a protective factor, but we get sick.
Oh yeah, I agree with that. This is no miracle cure. So just to be clear, even if every one of us did all these lifestyle modifications and took the appropriate tests and did the appropriate medications verbatim and perfectly, it wouldn't be 100% eradication of the illness. That won't happen. But if you have the illness, which may be genetic or polygenetic or random or repeated events in life triggering it, whatever it is, if you pay attention to these things, the degree of disability with that same illness will be significantly less. So I think it's an important point. My argument is not that we can prevent the disease altogether. My point is that we can reduce the risk of the disease. We know that. And if you have the disease, we can reduce the disability it causes.
If there's Alzheimer's in your family, do you recommend a scan?
So that's a very good question and a common question. And I think it's worth knowing that genetic causes for Alzheimer's disease, in the traditional sense, you have one gene and therefore a 50% chance or a 25% chance of your offspring having it. In that sense of monogenetic diseases, we call them. is possible, but it's very rare. It's almost all, it's probably way less than 4% overall, and it's almost all of the people that come from a specific region in Colombia. So it's very, very rare. There is some increased risk in family with risk predisposition because of what we call polygenetic risk factors. But we're talking maybe 1,000 genes. It's not different from diabetes. If your mom or dad had diabetes, you have an increased risk of hypertension, because there is lots of genes that we get from our parents, all of them, and they can realign to give us that increased risk. But it's not the worry we should have in a real sense, because the risk of genetics causing it is very small compared with the risk of all these other factors we're talking about. Okay. So just because you have a family history is not sufficient reason really to have a specific test or a scan. And because you're alive with a certain age, we should be having a scan in the sense of a brain check, but not a brain image, just to go back to the question. Yeah, Steve.
If I understand you right, ideally, as opposed to where we are now, everybody who's aged, say, 40 and older should start with a brain check right now, tomorrow, and then, depending upon the individual, it might be 6 months, it might be a year, 3 years, and we're sitting today, and if I call my PCP and say I'd like to have a brain check, and I'm not my age, but any age, the PCP is going to say what? Not a chance in the world, right?
Yeah.
They're not equipped.
So I'll give you the numbers. So currently, as I've mentioned, it is part of the Medicare benefits for the annual wellness exam. So it should be part of the checkup annually that we all get.
So I could call my PCP.
So you could call, but right now, less than 40% of PCPs actually do a brain check as part of the wellness exam.
And would the PCP be doing that check?
Mm-hmm. Only less than 40% do right now, because of the challenges of workflow, of the tools, and so, what we were talking about. I think that a lot of that, frankly, is going to change, and the catalyst for the change, I just gave a talk to the Grand Rounds at BI today, in fact, this morning, and talked about this aspect I'm going to mention now, but in the same sense of your question. The catalyst for the change is the fact that you all may have heard that as of January 6th, there is a medication approved by the Food and Drug Administration called lecanemab, that is an antibody against amyloid, one of the substances that accumulates in the brain in Alzheimer's disease, and it's the first time that any drug of that nature has shown a clinical benefit. So not just chemically decreasing the amyloid, but actually clinically people are better and are slowed down in their dementia by about 25%, a little bit more than 25%. So there is a real effect. It's not a massive effect, but it's a real effect. And with that, we know that early detection is critical, early intervention is critical, and I think that's going to be a catalyst of change. It's not going to be a silver bullet medication, but I think it's going to lead to people wanting to go and check and be checked, because if you have it, you could do something about it, and you need to do it early. Sorry,
Well,
1,
there's
2, 3.
a couple questions related to that online. What medications are coming down the pipe that you're interested in? And also, are there any computer-based home tests you'd recommend or think might be coming down the pipe?
Yeah, both great questions. So there is a lot of medications coming down the pipe, mostly for Alzheimer's disease. As I mentioned, lecanemab is approved by the Food and Drug Administration. We'll find out in July whether CMS covers it or not, whether it's going to be covered by Medicare or not. So more to come. We don't know yet, but it's only one of a series of medications in that class. They're called monoclonal antibodies against amyloid. In this case, there's also some against tau. Tau and amyloid are the two proteins that cause the damage in Alzheimer's disease. And that approach to therapeutics can be expanded. So there are other proteins that are abnormal that account and cause other forms of dementia. And there is work going on to get monoclonal antibodies against those also. So even in 2023, the results of 3 other phase 3 clinical trials for 3 other drugs are expected to be released, and the studies are being completed. So we could end the year with potentially 4 new medications for this kind of illness in that class. In addition, there is other approaches therapeutically with technology, as I mentioned briefly, and with pharmacology. Home-based assessments be fantastic to have. I've been advocating briefly that we need the technology advances to actually empower each one of us to have control of our cognition. But the tools that are available right now are not very good. So they're not very good for 2 reasons. One is they're not very sensitive in the way that they obtain the outcome. And they don't tell you what to do depending on the results. They just give you a result. The simplest way I have to explain it, and the way I think about it is, you may not know whether I know anything about car mechanics or not. But if you come to me and ask me, can you check my car? And I open the car and I start looking, very quickly you have a sense of whether I know what I'm doing or not. At the end of the day, maybe I solved the problem. By the way, I don't know what I'm doing. So, but maybe by chance even I solved the problem. A lot of the tests that we do look at the output, but they don't look at the process. They don't capture how you go about solving it. And yet that matters a lot. And so technology would allow us to capture the process with great precision, and I think the new generation of tests that are coming down the pike will capture that, and with that we'll have tools that we can then use at home, and be wonderful. Yeah.
Could you just to be specific about if you, today in 2023, if you go in and ask your PCP for a brain check, what would you hope the PCP would actually do?
First of all, I would hope that they would say, that's a great suggestion. Second, I think they would say, well, we need to plan for it because I don't have the time right now. So I think we need to be realistic about it. I think they do a great job. But I think at the end of the day, what I would hope is that despite the limitations of the tests that I was mentioning, that they would use one such tool to assess formally. Yeah. And do an assessment with that, and at the very least establish a baseline and be able to reassess it. Or if there is some abnormality, curbside or consult somebody. And there, as I say, there are people that who are doing that right now very successfully. I have a lot of referrals from primary care physicians that I think the world of and respect, and who contact me to say, this patient had this testing done, and I'm concerned about this aspect. So there is a lot of great work that is being done as part of this. My argument is that it's not at scale. It's individuals that are doing it, and I think we need to adopt it as a healthcare system kind of process. Yeah.
It's not a Jeopardy question, but it always comes up when I'm watching Jeopardy. That, that whole prevalent, I think that, I just wanted to
Prevalent, yeah.
that, right? And then the other question was, this whole idea of, yoga, meditation, prayer, right?
Mm-hmm.
I mean, I'm, not the holy roller, but I have to say that more and more I do it. Maybe it's a function of my mother with being very religious and, just say something 5 minutes a day. But I'm curious your, opinion on kind of how that all fits
Yeah,
in,
so I'm happy to address both. So prevalent in similar substances, there is a lot of supplements of sorts that has turned into $1 billion business that don't really do anything. I mean, that's there is not I should put it differently. There is no scientific evidence in appropriately designed trials that they actually make a difference. If you take it and it helps you, that's awesome. All the power to you. The power of placebo is phenomenal and it's real. It's real in the brain. So I mean, we have research going on. I have research going on where we're trying to enhance placebo effects. So I think it's great. But it's different than to say it's those substances doing it. It's the expectation, the hope, and so forth. And maybe there are other ways to engage that.
I'm incredulous. Yeah.
No, yeah, I wasn't. Yeah,
I get your answer because I
yeah.
look, this is, plus within Jeopardy, there's probably 15 prescription ads, so I don't know which one to take anyway.
So I yeah, but the other aspect is equally important, which is that part of that purpose in life conversation that I was mentioning, religious beliefs, transcendent personal beliefs, are hugely important and hugely powerful, and so the evidence that prayer done for you makes a difference in you, if you don't know about it, is very poor. The evidence that prayer done for you, if you know about it, does something for you, is very strong. And so again, it's a case where your hope, expectation, your own attitude, your own mindset plays a very big role. And if you can get that with the gift of faith, that's wonderful. There is a lot we know about the substrate of that faith in terms of the brain circuitry that it engages. So there's a whole neurobiology of religiosity that is increasingly developing. And it has to do with circuits of the brain that will promote resilience and reserve that I was talking about. So, yes.
Is anybody doing any research with psychedelics?
Yes, there is a lot of research with psychedelics, mostly for mental health, more so than for cognitive health per se. But perhaps one thing that I should have mentioned is that oftentimes we don't think about it, but 60% of individuals with dementia develop depression. So the comorbidity between depression and dementia is very, very high. And it's not simply because you get depressed, I'm trivializing, because you realize you have cognitive problems. It can be the first manifestation of the dementing illness. In about a third of cases of Alzheimer's disease, the first manifestation is apathy, lack of mood and initiative, depression broadly speaking, but it's the first manifestation of Alzheimer's. So in that setting, there is an increased attention to psychedelics and other interventions for mood disorders, and I think it's going to be increasingly looked at in the setting of dementia, because part of the way that they work is by upregulating synaptic plasticity, so neurons connect through synapses, and in illnesses that cause dementia, in Alzheimer's disease, for example, what floating amyloid does is reduces the efficacy of those connections and effectively makes our brain less capable of learning. But psychedelics are one way to increase the connectivity through synapses and potentially upregulate the plasticity of those systems.
A lot of people as we age, there's depression, anxiety, all kinds of stress, all kinds of things like this. And, maybe we're on all kinds of medication because we have different, blood tests show high cholesterol or a little of this or a little of that. Is there a problem with this? Are we looking at brain fog from some of these medicines, like the statins that are just like given out like candy?
So those are great points. So I tell residents that the number one thing to do in assessing somebody with dementia is decide what medications to take off. So oftentimes we are on medications, or people are on medications that are contributing to their cognitive problems. And so that's the first comment. The second comment is that we are in a society that is very medicalized. I didn't get into medications for dementia on purpose because I wanted to get another thing across. But it's easy. It's for all of us to lapse into give me the prescription. What should I take for it? It's like, well, what you should take is exercise. Yeah, okay. But give me the medication. No, you don't understand. Your prescription is go to the gym, get a trainer, and train 5 times a week. Yeah, okay. But what should I take? It's just like we have a hard time, right, with very medicalized mindset. And so with that, there is a definite abuse of medications in the hope that some silver bullet is going to cure us all. Part of the point I was making, also one of the questions was about it, is that we're not going to cure it all. We're going to have to live better with some of these illnesses. And so that's my point. The final aspect of your question that I think is relevant is the question of statins or other medications. So while it is true that we abuse medication, while it is true that there are medications that contribute to cognitive problems, I don't think there is any evidence that statin is one of them. And in fact, oftentimes in the setting of dementia, because it's part of, in some ways, aging, there are little strokes that accumulate in our brain, and preventing those little strokes by a baby aspirin and a statin is actually the best way to do that. And so it's probably not a bad idea to take a statin, but it'd be a very good idea to avoid Benadryl or to avoid benzodiazepines or excessive number of sleeping medications.
Has there been any extensive study of the family life of those people who have dementia, what type of families that they come from?
Yeah, there are even lifelong studies on brain health, and in early childhood supportive family life actually makes a difference. Statistically speaking, it's a predictor of reduced risk of dementia. So there is no doubt that our parents can make us exceedingly talented, gifted, and happy, and the opposite is also true.
And somehow it's going to be very difficult for the research to begin to enter into education. I'm not talking about college necessarily, but the lower education, K through 12. It seems to me there's a lack there of information that should be shared with the young people at whatever age is appropriate.
I think that there is a challenge in education. I think the good news is it appears to never be too late to start doing things for all of us differently. But the goal, I agree, has to be a lifelong program of brain health that starts with appropriate education in childhood. But again, there's going to be things they're hard to control. Right? So there's a lot of that has to do more with public health than with specific medical care aspects, but they're extremely important. Yes?
What about social media and you see kids, but all of that technology causing people's brains to...
So all the technology is causing people's brain to change. So let me start with that. We don't know yet. So the first point I think is important to realize is that it does cause the brain to change. So the thumb representation of a generation of people who got the QWERTY keyboards is different than the size of the thumbs of people who type with all fingers these days.
Literally?
Literally. Roy Hamilton did that study. So the size of the hippocampus of taxi drivers in London before GPS was literally larger than the size of hippocampi of people who are taxi drivers today in London. So technology changes our brain. Now that is not necessarily good or bad. It just means you need to be aware of the changes that it's going to impose. So humans are social beings. We know that the relationship I establish with you if I'm seeing you physically, it's not a value judgment, but it's fundamentally different than the relationship I can establish with you if we meet for the first time via Zoom and never meet in person. I happen to believe it is evolutionarily driven. You know, as evolution goes, human lifespan is less than half a second of the clock of life as we know it. So if you think the beginning of Earth is the beginning of the first hour, we are the last second of the last 24 hours. So we're incredibly recent things. And a lot of what we have developed with technology has fundamentally changed, which is anchored in a long history of evolution. Relations for humans are linked to what we can reach. If I can protect myself or attack you, depending on what I need to do, I need you close. And if I don't have a way to reach you because you're on the other side of a computer, that will change the way we relate. Doesn't mean we cannot establish relationships, but it does mean that they will be fundamentally different. And I'm talking brain activity different. We know that's the case. Whether that is the reason why it's much harder to be really nasty to somebody who is 10 feet from you than to be really nasty to somebody who you don't even see because it's on the other side of a text or a social media. Whether that's the reason, we can debate. I happen to believe it is. But I think there is good evidence that maintaining relationships using technology is possible if you have met them before in person. If you just have media and technology developed relationships, that fundamentally changes the relationship, including the fact that it's much less permanent a thing. It leaves less mark, literally, in your brain. So I think, the fact that current generations plan to go out and do go out, but do so by text and never call, never talk with each other and so forth, changes the dynamics, 100%. Maybe ultimately it's better, I don't know. But initially it poses risks to the point you're making, and we need to be aware of those risks.
One more question.
Sure.
So if you're managing all of your lifestyle pillars, what can you expect in terms of therapeutics at the Woke Center? You mentioned PET scans and spinal taps. What do they show and what interventions are available?
Well, what they show depends on what you have for a problem. What tests are done depends on the issues that you have. If the question is specifically about the Woke Center, what is different from other centers is that it is multidisciplinary, like many places are, but the emphasis is not on the neurologist or the psychiatrist doing the diagnosis, but rather on the support needed for the travel, for the course of illness, for the living with the illness, both for the patient and their family. And so that engages psychologists, social workers, resource specialists, and so on. At the same time, as in parallel to that, there is physicians and nurses and geriatricians and psychiatrists addressing with medications or experimental interventions the taking care of the biological aspect of the illness, so to say.
Thank you. Great. Thank you so much.
My pleasure. Thank you.